We'll start with IVUS-guided proximal cap puncture. We have uh, experienced yesterday, how we do IVUS-guided cap puncture, and I'll take you through the philosophy of this whole thing. Yeah. So if you look at any algorithm of CTO intervention, your intervention starts at analysis of proximal cap and distal vessel. If you have a clear proximal cap, then good distal vessel where you can reach, then you can start your antigrade wiring. If you don't have a clear proximal cap, that's what is, you can see here, this is an APCTO algorithm. Uh, that's when, you need IVUS to clear your cap and, wire it. So when you have an ambiguous cap, you need another imaging modality to make the cap unambiguous so that you can wire it. So that's where we start proximal cap puncture in an ambiguous cap. So have a look at this. This is an Austral LED CTO, so which we have shown you yesterday. And if you don't do IVUS-guided cap puncture, what can happen to this patient? See, if your wire goes subintimal, okay, to start with, you lift a flap, and that flap can occlude LCX. So that can be a on-table catastrophe, all right? So that's a consequence of, wiring, without confirming wire position in the proximal cap. And if you go retrograde, without any anti-grade preparation, and if your retrograde wire enters LMCA, right, and you do balloon dilatation subsequently after externalization, again, you can close LCX ostium. So what is most important here is, this is an extreme case of, ambiguous cap. First, you do antigrade puncture under IVUS, which acts as either antigrade preparation, or you might be successful, if your entry is perfect. So once entry is perfect, and if you reach distal lumen, that's fine. You can finish your case. But if you're not able to reach distal true lumen, then you go retrograde, right? And then this antigrade cap puncture acts as a preparation, okay, for receiving your retrograde wire uh, into your antigrade catheters. Because your puncture is done under IVUS guidance, you can do a reverse cut here. So you can do a reverse cut beyond the ostium, right? And your retrograde wire should come into the space created by balloon, right? Here itself. So your retrograde wire should be, at least 10 millimeters away from LED ostium. Never come close to LED ostium. And we can also use a guide extension, send a guide extension, and receive retrograde wire away from LED ostium so that you won't lose LCX. So IVUS-guided cap puncture is very, very important in these kind of cases. And I divide this procedure into 4 steps: identification of proximal cap, and then is wiring technique, and confirmation of central wire entry, and then consolidate your position with microcatheter and de-escalate. Okay, so these are the steps. You can see before you do IVUS-guided cap puncture, you see this vessel, you have a side branch, no doubt about it, and there is a CTO, but this side branch is not habitable for a IVUS catheter. See, you can't send a wire into it. You can't really send an IVUS catheter into it. So it's impossible to do IVUS guided wiring. Here you have a good side branch, but very loopy vessel. So often, your IVUS will keep moving when you position IVUS into such loopy vessels. So it becomes difficult to really do an IVUS-guided cap puncture. You see this side branch at proximal cap. It's a big one. So you have a good length of side branch. As I told you, You need at least a tip to transducer distance. In Boston catheter, it is around 20 mm, if I'm correct. So that is the minimum length you need, and width, the catheter, width. So this is the good width and good length. You can do IVUS-guided cap puncture, but only problem here is septals are 90 degrees. So when you're putting IVUS in septals to puncture ambiguous cap in LAD, 90 degrees vessel may not give you a great visibility, right? So to start with, so the angle, lesser the angulation, better the visibility of ambiguous cap and side branch. Identification of proximal cap is the first step. Once you decide IVUS-guided cap puncture, you can see here, this is an oscillatory CTO, and you have a big ramus as well as good sized LCX. And you can see, it's almost like from ostium, it is absent. So here what you can do is choose the branch which is close to your proximal cap, that is ramus, okay? If you do it from LCX, it's a 90 degrees vessel, so your visibility will be very poor. So do it from ramus. So lesser the angulation, better the visibility in IVUS-guided cap puncture. So went into ramus, did an IVUS, you can see now. How to identify, especially from ramus. So you have LCX. Often when you're doing IVUS from ramus, so yeah, you can see here. So your LCX comes at 8 o'clock and LED comes exactly opposite. That's at 2 o'clock, right? So that is one way of understanding. But the way how we identify is, first is the vessel size jump. You see from first to third picture, okay? The first one is only ramus. The third one is actually LMCA, right? So there is a jump in size of the vessel that indicates, yes, that side branch is there. And second is disappearance of media. You see, this is a media, right? When you're coming back, at some point, media will disappear. Okay. See this, here the media is present, and here, from here, there is no media. You can see here the media is present. From here, there is no media, right? So the absence of media and step up in size indicates the location of side branch, right? So yeah, once you identify, I can see here. So yeah, sorry. So first, there is nothing in the arena of IVUS, and you see something is appearing there, and that comes close to the branch, and then it joins, the main vessel. This is the confluence, and this line marks actually the media of the vessel. Okay, and then again you can see, so and then there is a LMCA, that's a size and jump of the vessel. So this is how you can identify or locate proximal cap. Sometimes identification is very difficult. As I told you, when you do IVUS from LCX to uh, clear your proximal cap of LAD. So, and if cap is calcified, here it is 90 degrees. That's one problem. Another problem was cap is very much calcified. So it's very hard to identify the cap in such scenarios. Okay, so calcified cap and angulation are quite unfavorable, for IVUS-guided cap puncture. Wiring of proximal cap under IVUS, once you identify cap, you have to wire it. So these are different methods, with which you can do. This is a 7 French guide with IVUS and fine cross are allowed through the 7 French guide. 8 French guide, if you want to go with Corsair and IVUS, whatever IVUS I'm talking about is OptiCross. So if you want to take these two, you can go through 8 French guide. And if you want to use a slipstream system, this is both IVUS and W-lumen catheter on the same wire. So you need a 8 French guide, so which we will show you in the next live inbox case. So, and wiring of proximal cap under IVUS, you position tip under IVUS onto the proximal cap and just advance. And you can also use 3D wiring algorithms to do that. So which I don't want to confuse you. Uh, yeah. So which wire for IVUS-guided cap puncture? So is it Gaia or Harnett? You have seen we did a live case yesterday wherein I used just Gaia, but Gaia works if angle of attack is very less. I mean, I would say probably less than 40 degrees. Okay, if the angle of attack is more, it doesn't work because you can see here. Uh, sorry, I think yeah, you can see here. This is Gaia. This is Harnett in the same case, and how Gaia buckles. See, when I push Gaia after positioning it on proximal cap, it just buckles because the shaft is not that stiff. Okay, and if you look at Harnett, it won't buckle. It will just get into the vessel, without buckling. So here it buckles and goes into your ramus. Here, it just goes. It gets into your proximal cap. Yeah, that's mainly because of the stiffness. So that's the reason Harnett or Conquest are better wires for proximal cap puncture than Gaia. And you can see here again, so another case where you can see, there is a fibrous speck of calcium sitting here, and this is the Gaia. When I'm pushing Gaia, you see how it is buckling, right? So it just buckles, okay? The moment you realize it is buckling, you should understand that's not a great wire, to puncture that cap. You have to come out and take a different wire with high tip load and high stiffness, okay? That's basically, high penetratable wires. And same thing, you can see here the way how Gaia is buckling and how your harnett goes in, right? And once the harnett goes in, then you can de-escalate back to Gaia 2 and you can finish your procedure. Anyway, what is the tip shape we use for cap puncture? So we use one, primary band as well as a secondary band, and the overall angulation depends on the angle of attack. So what angle of attack you have in that ambiguous cap that decides the overall the angle which we use with the secondary cow. And wiring a proximal cap under IVUS, yeah, I can see this is a harnett. I'm just positioning on cap, and that's all is done under IVUS. We do under IVUS. Once the tip is positioned onto cap, then you just push it. That's all. It gets into the vessel. How far you have to push? That's another thing, which we have to keep in mind. So it's better you push up to the secondary curve, not beyond the secondary curve. The moment your secondary curve is going into the vessel, your primary curve will be approaching the intima. You understand? So never go beyond secondary curve. But sometimes when the angle of attack is very less, there you can even go deeper as well because you're not taking a big angulation. But when you take a big angulation, so it's forbidden to go beyond secondary curve because the wire tip can go back into subintima again. So now, once you puncture, you have to confirm with IVUS again. Look here. So this is a wire, right? And you can see, throughout the wire should be within the media. That's a, that's what you have to see. That's what says it's an ideal puncture, which I'll show you now in frame by frame. You can see this is this is the wire, and you see this is basically media which I'm marking. So and you can see this is wire, and this is wire, and this is media, right? So it is within the media, right? So that's wire, this is wire, and this is within the media. And here you can see this is the media at the confluence, okay? And you see the wire is between the two hinge points, right? So that says it's a correct position, right? And you can see here, so the cap is here. So yeah, this is the cap, right? And your wire is here. You can see this is the wire, this is the wire. So the wire with which I punctured. So it's a subintimal entry, okay? Cap is here. And later, we took again Hornet, and that was Gaia 2. And yeah, now you can see it's in perfect puncture. So had I gone with the same puncture, so the first puncture and, did everything, then I would have occluded, LCX. Okay. This is an hostile LED ambiguous CTO case. So you have to identify, subintimal entry versus ideal cap puncture. Once you confirm that your wire puncture is good, you have to consolidate your position, okay, by advancing microcatheter and de-escalate wire. So why it is important, right? So this is your cap puncture wire. As I told you, we give a secondary curve. And once it is beyond the secondary curve, the tip will go close to the intima. If you push more and more, again tip will go into subintima. See, your entry might be correct, but again you will enter into subintima subsequently. So that's the reason you just push microcatheter inside, right? Then pull the wire out, okay? And then you de-escalate wire to 1 mm tip. See, 1 mm tip, the advantage is it tries to stay in the intima and you can track intima better, okay? And go back to Gaia, right? 1 mm tip and continue your wiring, okay? So that is what you have to do. This is very important step. And yeah, so you can see here, so we punctured with Harnett, right? And then microcatheter is advanced. You can see in second image. And then this is Gaia 2 with 1 mm tip. And now, we advanced Gaia 2 and we reached, in fact, distal true lumen with Gaia 2, since it is a short CTO. So sometimes you can see, I mean, it's a slipstream system. Probably we're going to show in next live in box case. Anyway, both your IVUS catheter as well as Crusade catheter, double lumen catheter, are on the same wire. So what we have to do is pull this wire back. Your IVUS catheter is out of the wire, and then pull the IVUS catheter out, right? And then you can take a tapper balloon and remove Crusade, and then you can exchange to Corsair. We'll show you anyway next case. So, and once that is done, you can see here. See, we removed Crusade and Corsair is into the CTO, and sometimes how your wire behaves. So the conquest was stuck here because of the bend. So it was stuck there. And the moment I switched to Gaia 2 with 1 mm tip, see how dramatically it went into lumen. So the tendency of 1 mm tip is it stays in the intima and it stays in the lumen in general, okay? So it just went, yeah, now you can see it's in the lumen, yeah? So successful IVUS-guided cap puncture, but sometimes you may not be able to reach distal true lumen. So your entry into cap is correct, but you couldn't exit into distal true lumen for different reasons. So you can see this is a ambiguous oscillatory cap. You see the puncture was perfect. Your wire entry is perfect. And we confirmed it. And then we had uh, removed, exchanged Conquest Pro back to, Gaia 2 wire. After advancing microcatheter, you can see that's a Corsair, which we advanced and then de-escalated to Gaia. Gaia is further advanced, but we were not able to decipher, where this wire is. See, the vessel visible retrogradely, and your wire is completely in a different track. So that's when we realized, I mean, it's better to go retrograde because there is some ambiguity in the course of the vessel, which you can't really, solve without having a retrograde access. So, um, if you want to do a parallel wiring in that scenarios, okay, after I was guided puncture, you can, what you can do is, so once your wire is inside and your distally the wire went into subintimal, okay. So what you have to do is you create a space. See, you confirmed your I was cap puncture is perfect. You create a space here, right? You don't know where your wire went into subintima. Create a space here at the ostium, and then take a W-lumen catheter. This is a W-lumen catheter, and your over the wire exit should be beyond the ostium of LID. That means you are ensuring your second wire is also going through the same entry, which you have done under IVUS. Okay, no point in doing another IVUS guided cap puncture. You understand? So this is how you can ensure your second wire also goes through the same puncture, and then you can advance your second parallel wire. That's also one thing which can be tried, and but when you have a problem with ambiguity, uh, you can also go retrograde. But when you're going retrograde, how to handle it? As I already explained, see this is antigrade balloon. Your balloon should be at least more than 10 mm beyond the ostium. This is your retrograde wire. Okay, your retrograde wire shouldn't come to ostium, so it's forbidden. Okay, wire should enter into lumen beyond the ostium. The whole idea is you shouldn't create a dissection and occlude LCX. Okay, so yeah, your entry, I mean, harnessing your retrograde wire into antigrade catheter or guide extension should happen beyond this point. This wire shouldn't come, proximal to this line. So that's a key, right? So, I mean, that's what we did. But in fact, my wire a little bit reached ostium. So that's when what happens is you can see here. So two wides are coming, yeah, two wides are coming from same entry. So my entry is perfect, but as the wire approached close to LMCA, there is a lot of intramural hematoma, which you can see here in LMCA. Okay, this is all intramural hematoma. That is the reason your wire shouldn't come to the ostial LID. Then we end up in doing a two stents technique, because once there is a intramural hematoma in LMCA, it's safe you stunt from ostial LMCA. Never stunt from ostial LID, because the moment you stunt from ostial LID, whole hematoma will shift into LMCA, and your LMCA will get occluded. Okay. Okay, so this is another case. You can see ambiguous cap. We did an IVUS guided cap puncture. You see the wire position is perfect. Yeah, so it's within the media all around. But what happened subsequently is, that wire went into subintima. You can see here, because of the bend, the wire went into subintima. So, and that's when, we had to go retrograde. And we went retrograde, you can see here. But the microcatheter was stuck here. And then, yeah, and we changed microcatheter to Corsair. Even that was stuck here. It's not going beyond. And that's when we use retrograde wire as a marker to do stingray re-entry. So you can loop retrograde wire CO03, which acts as a lumen marker, and then we did a re-entry with stingray wire. This is stick and dry with Gaia 2 wire, and you can see this is the final injection. So see this. See, you can also do IVUS guided retrograde, proximal cap puncture. So you can see this is a OM total occlusion, right? And post CABG, and a lot of clot in the graft. So we didn't want. It's almost like 8 years post, 8 to 10 years post CABG. So kind of degenerated graft. We didn't want to do any venous graft intervention. So what we did, see, not much of space here because probably vessel is negatively remodeled. So we just went retrograde and bring your antegrade IVUS catheter here, and you puncture with retrograde wire the proximal cap. So this is a retrograde puncture of proximal cap, and you can see this is how we wide, and you see here this is the IVUS catheter, and this is Gaia 2, and you can see this is a proximal cap. I'm doing IVUS from LCX. This is a proximal cap, and then we started puncturing cap. If you notice, this is the wire here. The retrograde wire is somewhere here. So it's almost on the other side of the carina, right? So when the wire is on the other side of the carina, yeah, I can see here, this is a wire, and this is the space created by the wire. Then entire block will shift onto the distal vessel, and vessel will get occluded. Okay. So the wire should be close to carina. Your entry into the main vessel should be close to carina. See, this is what. See, if wire comes like this whole block will be shifted this side. If the wire is coming from here, close to carina, block will be shifted to the other side. So you won't get, you won't occlude your distal vessel. So, that's what we did. So we again, yeah, you can see here, this is the wire now. It's close to carina. So before it was away from the carina. So we punctured, and then, we confirmed. You can see this is the carina, and the wire is close to carina. And yeah, we entered close to carina, and then we punctured, and then we completed. You can see, the distal LCX flow is preserved, right? Had I continued with the first puncture, probably, distal LCX would have gone completely, and we occluded even venous graft. That's what we practice, in our center. So this is the final result. To conclude, IVUS-guided cap puncture makes ambiguous proximal cap CTO PCI more predictable. Extreme angle of attack and calcified proximal cap are unfavorable, for IVUS-guided cap puncture. Cap identification, wiring of cap, and confirmation of central wire entry. Every step must be done under IVUS, and choice of wire and tip shape plays a major role in cap puncture. Uh, Embed microcatheter and de-escalate after puncture confirmation. And parallel wiring can be done through double lumen catheter with OTW port kept beyond proximal cap. A reverse cart after IVUS-guided cap puncture is possible and more predictable. And you can use direct reverse cart with end balloon technique, and you can also use guide extension, for harnessing wire beyond, ostium. Stay away from proximal cap with retrograde wire when you are doing reverse cart. IVUS-guided retrograde proximal cap puncture is possible, and you can do it as close as possible to the carina so that you don't lose distal branches. Thank you.